A patient is brought to the emergency room with an acute severe asthma attack. Which drug is your immediate first line choice and how does it work? Yeah, then you have to answer like this. The drug of choice is short acting beta 2 agonist like salbutamol. It works by stimulating beta 2 adrenergic receptor on the bronchial smooth muscles by activating adenylyl cyclase, increasing cyclic AMP, and causing rapid bronchodilation. Yes, and the second question is why do we give inhaled corticosteroids like budesonide in chronic asthma even if they don't cause immediate bronchodilation? Okay, the answer is like corticosteroids like budesonide are anti-inflammatory agents. They are not bronchodilators, so they decrease airway hyperresponsiveness and mucosal edema by suppressing inflammatory cytokines. So there are they are used for long-term prophylaxis and control, not for acute relief. Yeah. So the third question: what is a common local adverse effect of inhaled corticosteroids like fluticasone, and how do you counsel the patient to prevent it? Yeah. So you can answer to the examiner like this. The most common local side effects of fluticasone are oral oropharyngeal candidiasis, or it's also called oral thrush and dysphonia. So we counsel the patient to thoroughly rinse their mouth with water and spit it out after every inhalation. Okay, now the fourth question: why must you be highly cautious when prescribing oral aminophylline or theophylline? Okay, why? Oral theophylline has a narrow therapeutic index. A slight increase in blood levels can lead to severe toxicity, so manifesting as cardiac arrhythmias, severe vomiting, and convulsions. So we should not. Yeah. Okay, we should be cautious. Okay, the fifth question is if a patient on chronic theophylline therapy develops a respiratory tract infection, is prescribed erythromycin. Okay, what complication do you anticipate? What may be the complications? Yeah, so you can tell like this: theophylline clearance will be decreased. Why? Because erythromycin is a cytochrome P50 enzyme inhibitor that stops the metabolism of theophylline, so leading to toxic accumulation. So this one, what theophylline therapy develops a respiratory infection and is prescribed erythromycin. What complication? So you can answer this type of answer. Yeah. Then the sixth question: why are non-steroidal anti-inflammatory drugs like aspirin contraindicated in certain asthmatic patients? Yeah. Okay, aspirin blocks the cyclooxygenase pathway. This shunts arachidonic acid pathway entirely to lipoxygenase pathway, causing overproduction of leukotrienes. Yes, this causes severe bronchoconstriction known as aspirin-induced asthma. Yeah. So non-steroidal anti-inflammatory drugs like aspirin contraindicated in certain asthmatic patients. Yes. Okay. The seventh question: how do drugs like montelukast and what is their preferred clinical route? How do drugs like montelukast work? Okay. Okay. Montelukast blocks the action of leukotrienes to prevent bronchoconstriction. Okay, and mucus secretion. Okay, it is administered orally and is highly effective in aspirin induced asthma and exercise induced asthma. What is the drug? The montelukast. Okay, that is like leukotriene antagonist. Yeah. Okay, then the eighth question: what is omalizumab and what is its specific indication in respiratory medicine? Yes, omalizumab is a monoclonal antibody against immunoglobulin E. It binds to circulating IgE, preventing it from attaching to mast cells. It is indicated for severe persistent allergic asthmatic condition uncontrolled by high dose inhaled corticosteroids. Yeah. Then the ninth question: why are anticholinergics like ipratropium bromide preferred over beta 2 agonist in chronic obstructive pulmonary disease, that is COPD? Yeah, in COPD, vagal parasympathetic tone is a primary reversible component of airway obstruction. So, ipratropium bromide blocks M3 muscarinic receptor to effectively reduce the vagal tone and decrease the mucus hypersecretion. Yes, once again, I am repeating. In COPD, vagal parasympathetic tone is a primary responsible component of airway obstruction because the tone is increased. Yeah. So ipratropium bromide blocks M3 muscarinic receptor to effectively reduce this vagal tone. So, and thereby decreasing the mucus hypersecretion. So we can use in chronic obstructive pulmonary disease. Yeah. The 20th question: What is the difference between an expectoration mechanism and an antitussive mechanism? And can you name a centrally acting antitussive? Okay, so if the question is like this, you can answer like expectorants increase respiratory tract fluid to make cough more productive. Okay, and in contrast, antitussives suppress the cough reflex center in the brain. A classical centrally acting non-opioid antitussive is dextromethorphan. Yeah. Okay. Myself Vasit, just a medical student sharing high yield facts by day. Yeah. Hit follow button and let's keep building. Thank you.